So think about your body for a sec, right? It's this incredibly complex thing.
Yeah, like a huge, intricate organization.
Exactly. And how does let's say, the CEO in your brain get messages out to all the different departments? Tell the factory floor, speed up or slow down.
Right. It's not like sending emails down the hallway.
No, it's something much more fundamental, chemical signals.
It really is. It's this amazing network of chemical messengers, hormones, basically,
Yeah.
running the whole show. Everything from your energy levels, growth, stress response, keeping everything in this delicate balance. And when that communication network goes wrong, well, the effects can be profound.
Absolutely. And that internal comms network, that's the endocrine system. And that's what we're really diving deep into today. We've got this fantastic set of sources. You've brought really detailed stuff.
Yeah, clinical notes, research, foundational texts.
Our mission here is to unpack all of this layer by layer. We're not just skimming. We want to get to that, professional level grasp, understand the why behind it all.
Exactly. We'll hit the major glands: pituitary, thyroid, adrenals, pancreas, the key players.
And then look at what happens when things go off balance. The diseases.
Precisely. We'll look at the spectrum of conditions, how they arise, how they present. Think of it like exploring a really complex biological map.
Okay, let's start mapping then. Fundamentally, what's the endocrine system doing?
At its heart, it's the body's long-distance chemical signaling network, a collection of glands, highly integrated, maintaining metabolic equilibrium.
Through hormones, those are the messengers.
Right. The sources mention other signaling types too, like cells talking to their immediate neighbors, paracrine, or even to themselves, autocrine.
But endocrine is the big one for system-wide control.
That's the key. Endocrine hormones get secreted directly into the bloodstream. They travel everywhere, but only cells with the right receptor, the target cells, can actually respond to the message.
Like broadcasting a radio signal, but you need the right radio tune to the right station to hear it.
Perfect analogy.
Yeah. So how does the body avoid sending too much or too little of these powerful signals? It sounds like it needs tight control.
Oh, absolutely crucial. And it has these elegant control mechanisms. Often, a gland like the pituitary releases a stimulating hormone, a trophic factor.
The go signal.
Exactly. But then, the hormone released by the target gland, say, the thyroid circulates back and actually inhibits the pituitary from sending more of that initial trophic signal. It's negative feedback.
Ah, the thermostat analogy. Room gets warm enough, signal tells the furnace to shut off.
Precisely. Hormone levels rise, the initial stimulus drops. Hormone levels fall, the stimulus can increase again, keeps everything in that optimal physiologic range.
So disease happens when that thermostat breaks.
Yeah.
Or the furnace is stuck on high or low.
That's a great way to think about it. The sources group endocrine diseases like that. First, you have diseases of hormone quantity, too much production or too little.
Like hyperthyroidism speeding things up, or diabetes from lack of insulin.
Exactly. Those have clear biochemical and clinical effects. The second category involves mass lesions, tumors, or growths in the glands.
Okay.
These masses can cause trouble either by making hormones themselves, being functional, or by being non-functional, but just getting big enough to squash the normal gland tissue, causing a deficiency.
So a signaling problem or a physical space problem, or sometimes both.
You got it. And the sources really emphasize this. To understand these diseases properly, you have to integrate the morphology, what the tissue looks like, with the biochemistry, the hormone levels, the regulators, the downstream effects.
Makes sense. You need the full picture, structure, and function.
Absolutely. It's connecting the dots. So speaking of control centers, let's start at the top with the pituitary gland, often called the master gland.
The conductor of the orchestra.
Right. Though it takes its own direction from the hypothalamus just above it.
Yeah.
It's this tiny bean-sized thing nestled in a bony pocket at the base of the brain called the sella turcica.
So it's quite protective physically.
It is. But that tight space also makes it vulnerable to mass effects. It's connected to the hypothalamus by a stalk crucial connection with nerve fibers and blood vessels. The hypothalamus is really the ultimate controller, getting brain input and telling the pituitary what to do.
And together, they regulate most other endocrine glands.
That's the setup. Now, the pituitary isn't just one thing. It's got two distinct parts, or lobes.
The anterior and posterior lobes?
Correct. And they're very different. The anterior lobe, the adrenal hypophysis, is bigger, about 80%. Developmentally, it actually comes from tissue that migrates up from the roof of the mouth.
Wow, really?
Yeah, cool bit of embryology. This anterior lobe is the hormone factory. It synthesizes and secretes those trophic hormones that control the thyroid, adrenals, gonads, and also things like growth hormone and prolactin.
And the cells inside look different depending on what they make.
Historically, yes, they were classified by staining acidophils, basophils, but functionally, there are about 6 key cell types, each specialized for hormones like TSH, ACTH, GH, prolactin, FSH, LH.
Okay, so that's the factory. What about the posterior lobe?
The posterior lobe, the neurohypophysis, is fundamentally different. It's basically an extension of the brain, specifically the hypothalamus. It contains glial cells, pituocytes, but importantly, it contains the ends of nerve fibers, the axons, whose cell bodies are way up in the hypothalamus.
So it doesn't make its own hormone?
Nope. It stores and releases 2 peptide hormones that are actually synthesized in the hypothalamus and then transported down those axons.
Ah, like a warehouse and shipping dock. Which hormones are those?
Oxytocin and antidiuretic hormone, ADH, also known as arginine vasopressin, AVP.
Okay, oxytocin. That's involved in childbirth and lactation.
Primarily, yes. Cervical dilation during labor triggers its release, causing uterine contractions. Nipple stimulation after birth triggers it for milk letdown. Synthetic oxytocin is widely used to induce labor.
Critical functions.
And ADH. ADH is all about water balance. It tells your kidneys to conserve water, to reabsorb more, reducing urine output. It's released when you're dehydrated, basically sensed by things like increased blood concentration or decreased blood pressure.
And inhibited when you're overhydrated.
Exactly. It's absolutely vital for fluid and electrolyte stability.
Fascinating. 2 hormones, same release point, totally different jobs. Now back to the anterior pituitary factory. How does the hypothalamus control its output?
Through that stalk again, but this time mainly via a special network of blood vessels, the hypophyseal portal system. The hypothalamus releases tiny amounts of releasing hormones or inhibiting hormones into this portal blood.
So signals like TRH, CRH, GnRH telling it to release.
Right. And inhibitory ones like dopamine, which inhibits prolactin, or somatostatin, which inhibits growth hormone.
So it's a constant balance of go and stop signals from the hypothalamus.
Precisely. And the sources point out, sometimes pituitary problems aren't the pituitary's fault. They stem from an imbalance in these hypothalamic signals. That's key for diagnosis.
It really emphasizes looking at the whole axis. The sources even mention the specific transcription factors driving pituitary cell development, like PIT1. Why is that molecular detail important?
It's clinically relevant because those same transcription factors that guide development are often still expressed in pituitary tumors, the adenomas.
Ah.
So identifying which factors are present in a tumor helps classify it, predict its behavior, maybe even guide treatment down the line. It connects basic biology to pathology.
The tumor carries a fingerprint of its origin. Okay, let's talk clinical impact. What happens when the pituitary malfunctions?
It boils down to those 3 main scenarios.
Yeah.
Too much hormone secretion, hyperpituitarism,
Yep.
too little, hypo-pituitarism, or problems caused just by the physical size of a lesion in that confined space, the mass effects.
Let's tackle hyperpituitarism first. Too much hormone.
This usually means excess secretion of one or more of the anterior pituitary hormones. And the overwhelming cause, according to the sources, is a benign tumor of those anterior pituitary cells, a pituitary adenoma.
So a growth that's overproducing?
Exactly. Much less often, it could be generalized hyperplasia, a very rare pituitary carcinoma, or even hormones coming from tumors elsewhere in the body, or certain hypothalamic issues. But adenoma is the big one.
And hypopituitarism, too little hormone.
That's the flip side, a deficiency. And you generally need substantial damage, the sources say, around 75% loss of the anterior pituitary before you see significant symptoms.
What causes that kind of damage?
Several things. Ischemic injury, lack of blood flow is a big one, sometimes after traumatic brain injury, or a subarachnoid hemorrhage. That's actually quite common.
Really? Head trauma can cause pituitary failure?
It can, yes. Also, surgery or radiation in that area can inadvertently damage the normal tissue. Inflammatory conditions like sarcoidosis or infections, and, ironically, non-functional pituitary adenomas can grow large enough to compress and destroy the healthy parts of the gland.
So the tumor itself causes the deficiency?
Sometimes, yes. Another cause mentioned is a Rathke cleft cyst, a developmental remnant that can expand.
And you mentioned a key diagnostic clue earlier involving the posterior pituitary.
Right. If you see signs of anterior pituitary failure, plus posterior pituitary failure, specifically diabetes insipidus, the ADH problem, it strongly suggests the issue originates higher up in the hypothalamus because that's where ADH is made. Direct pituitary damage usually spares ADH production.
Makes sense. Now, those mass effects sound potentially serious given the location.
They really are. The pituitary sits right underneath the optic chiasm, where optic nerve fibers cross. So an expanding pituitary mass, like an adenoma, classically compresses these crossing fibers.
Leading to vision problems.
Yes, specifically a loss of the outer peripheral visual fields in both eyes. It's called bitemporal hemianopsia. It's a classic sign.
Like losing your side vision.
Exactly. And like any mass growing inside the skull, it can raise intracranial pressure, causing headache, nausea, vomiting. Then there's pituitary apoplexy.
That sounds dramatic.
It is. It's an acute bleed into an existing adenoma. The tumor suddenly swells, causing excruciating headache, rapid vision loss, maybe problems moving the eyes. It's a neurosurgical emergency because of the risk of circulatory collapse and even death.
Wow. So adenomas aren't just hormone factories. Their location makes them dangerous, and they're the main cause of hyperpituitarism.
By far. Arising from those anterior lobe cells, they're classified based on the hormones. They make sometimes one, sometimes two, like GH and prolactin together is common, sometimes more.
Who gets them typically?
Usually adults, peak age 35 to 60. We call them microdenomas if they're under 1 centimeter, macrodenomas if they're over 1 centimeter.
And the non-functional ones tend to be bigger when found.
Right, because they don't cause hormonal symptoms early on. They only become apparent when they get large enough to cause mass effects, like that vision loss or maybe headache.
Are they common overall?
Interestingly, autopsy studies suggest maybe 14% of people have one, but the vast majority are tiny, silent microdenomas found by chance on scans, incidentalomas. So finding one doesn't automatically mean disaster, but it needs checking out.
What actually causes them to form? Genetic mutations?
Yes, like other tumors, it's usually down to acquired mutations in genes controlling cell growth. About 5% are linked to inherited germline mutations, making people predisposed.
What specific mutations are involved?
The sources highlight a few key ones. For example, in about 40% of growth hormone secreting adenomas, there's an activating mutation in the GNAS gene. This affects a molecular switch, GS-alpha.
Okay.
Normally, this switch turns off quickly. The mutation breaks the off mechanism, so it's stuck on, constantly signaling the cell to grow and make hormone. That pathway isn't typically involved in other adenoma types.
So different types have different driving mutations.
Often, yes. Another example is mutations in USP8, found in many ACTH-secreting adenomas. USP8 normally helps recycle growth factor receptors. Mutations make it overactive, stabilizing receptors like EGFR, boosting growth signals. Understanding these pathways is key for future therapies.
And the inherited ones?
Germline mutations in genes like MEN1, part of the MEN1 syndrome, CDKN1B, PRKAR1A, or AIP, can predispose families to pituitary adenomas, often presenting earlier. Rarer mutations are linked to pituitary carcinoma or blastoma.
What do they look like under the microscope?
Typically, they're composed of uniform, polygonal cells in sheets or cords. Quite monotonous compared to the varied landscape of a normal pituitary.
Okay, let's run through the specific types based on hormone, starting with the most common lactotroph adenomas making prolactin.
Right, the most frequent type overall. Excess prolactin causes hyperprolactinemia. In younger women, say 20s to 40s, this classically disrupts periods. Amenorrhea causes milk production, galactorrhea lowers libido, causes infertility.
So symptoms that often lead to earlier investigation.
Exactly. Lactotroph adenomas are a common cause of amenorrhea. In men or older women, the symptoms might be more subtle, maybe just decreased libido, so the tumor might grow larger, become a macronoma, before it's found due to mass effects.
Is an adenoma the only cause of hyperlactin?
Oh no, lots of things can do it. Pregnancy, breastfeeding, stress. Many drugs, especially ones blocking dopamine, because dopamine normally inhibits prolactin. Anything pressing on the pituitary stalk can block that dopamine signal. Kidney failure, hypothyroidism too.
How are prolactinomas treated? Is it always surgery?
Actually, no. This is one area where medical therapy is often first line and very effective. Drugs called dopamine agonists, like bromocriptine, mimic dopamine's inhibitory effect. They usually shrink the tumor and normalize prolactin levels really well.
Good to know. Next up, somatotroph adenomas making growth hormone, GH.
Excess GH leads to different things depending on age. In kids, before the growth plates in their bones close, it causes gigantism. They grow exceptionally tall.
And in adults.
After the growth plates fuse, you get acromegaly. This isn't about height anymore. It's about overgrowth of soft tissues and bones. You see enlarged hands and feet, coarser facial features, a protruding jaw, prognathism, deep voice.
But it's more than just appearance changes, right?
Much more. Acromegaly carries serious health risks. Diabetes, hypertension, heart problems including heart failure, arthritis, muscle weakness, even an increased risk of colon cancer. It's a systemic disease.
How's it diagnosed?
You measure GH and also IGF-1 levels. IGF-1 reflects GH activity well. The gold standard test is the oral glucose tolerance test. Normally, giving sugar should suppress GH release. In acromegaly, GH levels fail to suppress or may even paradoxically rise.
Treatment, surgery.
Surgery is often the first approach. There are also effective medical treatments like somatostatin analogs, which inhibit GH release, or GH receptor antagonists, which block its action. Good treatment can reverse many of the soft tissue changes and metabolic issues. And an interesting detail the sources mention there are subtypes based on histology. Sparsely granulated somatotroph adenomas tend to be larger, more invasive, and less responsive to those somatostatin drugs compared to the densely granulated type. Morphology matters for prognosis and treatment.
Wow. Okay, lastly, corticotroph adenomas making ACTH.
These cause the adrenal glands to pump out excess cortisol, leading to Cushing's syndrome. The specific scenario of Cushing's syndrome caused by a pituitary ACTH-producing adenoma is called Cushing disease. These adenomas are typically small microadenomas.
Got it. So that covers the too much hormone side, mostly from adenomas. Now, hypo-pituitarism, not enough hormone.
As we said, decreased secretion, usually needing about 75% destruction of the anterior pituitary.
Let's quickly recap the main causes again.
Destructive processes are key. Tumors pressing on the gland, non-functional adenomas, other cellular masses, traumatic brain injury, subarachnoid hemorrhage, important causes, pituitary surgery or radiation, inflammatory conditions, Rathke cleft cysts, empty cella syndrome, where the space looks empty on scans but the gland might be compressed.
And problems starting in the hypothalamus.
Yes, tumors, radiation damage, infections up there can cut off the stimulating signals to the pituitary. And remember, hypothalamic problems can also cause ADH deficiency, diabetes insipidus, which pituitary destruction usually doesn't.
And very rare genetic defects, too.
Extremely rare, yes. Congenital lack of transcription factors like PIT1 leading to combined deficiencies from birth.
The symptoms must depend entirely on which hormone is missing.
Absolutely. GH deficiency in kids, pituitary dwarfism, growth failure, LH-FSH deficiency, reproductive problems, amenorrhea, infertility, loss of libido, loss of secondary sexual characteristics, TSH deficiency, hypothyroidism symptoms, ACTH deficiency, hypoadrenalism symptoms.
What about prolactin deficiency?
The main sign is failure to lactate postpartum. And one other interesting, lack of MSH, which comes from the same precursor as ACTH, can cause pallor, unusually pale skin.
Another unexpected sign. And the posterior pituitary syndromes, DI and SIADH, relate to ADH levels being wrong.
Correct. Usually linked to hypothalamic issues or other systemic problems affecting ADH release or action. DI is too little ADH effect, SIADH is too much.
Okay, a very thorough look at the pituitary. Let's move down to the neck. The thyroid gland. Metabolism's thermostat.
Good way to put it. Butterfly-shaped gland low in the front of the neck, 2 lobes joined by an isthmus. Develops from the back of the tongue area, which explains why you can occasionally find bits of thyroid tissue elsewhere, like lingual thyroid. Structurally, it's made of follicles, little sacs filled with thyroglobulin colloid, lined by the cells that make the hormones.
When it makes too much hormone. Hyperthyroidism or thyrotoxicosis. What's the difference again?
Thyrotoxicosis is the clinical state of having excess thyroid hormone affects the hypermetabolic state. Hyperthyroidism is specifically when the thyroid gland itself is overactive and causing that excess. So hyperthyroidism causes thyrotoxicosis, but you can have thyrotoxicosis from other causes too.
Got it. So what causes true hyperthyroidism, an overactive gland?
The big one, about 85% of cases, is Graves' disease. It causes diffuse enlargement and overactivity. Other causes include a hyperfunctioning multinodular goiter or a single hot thyroid adenoma making hormone autonomously.
And thyrotoxicosis without hyperthyroidism.
That's usually stored hormone leaking out or hormone from outside. Think thyroiditis, inflammation damaging follicles. Granulomatous, Duquesne veins, thyroiditis, subacute lymphocytic or postpartum thyroiditis, rarely thyroid tissue in an ovarian tumor, struma ovaria, or someone taking too many thyroid pills, factitious.
The symptoms of too much thyroid hormone sound like everything is just accelerating.
That's exactly it. Hypermetabolic state. Increased basal metabolic rate, feeling hot, sweating, heat intolerance, weight loss, despite increased appetite.
Heart racing.
Definitely. Tachycardia, palpitations, the heart works harder, can enlarge. Risk of arrhythmias like atrial fibrillation increases, especially in older folks. Over time, can lead to heart failure, thyrotoxic cardiomyopathy.
Nervous system effects.
Big time. Tremor, anxiety, irritability, hyperactivity, insomnia. Muscle weakness too, thyroid myopathy. Gut speeds up, more frequent bowel movements.
And the eyes. That's staring luck.
Yes, the wide-eyed stare and lid lag are common, partly due to sympathetic overactivity affecting eyelid muscles. But the true ophthalmopathy, with bulging eyes, proptosis, and eye muscle problems, that's specific to Graves' disease, caused by autoimmune inflammation behind the eye.
Any other systems affected?
Bones' increased turnover leads to osteoporosis risk. Liver changes. Lymphoid tissue can enlarge.
And thyroid storm. That sounds serious.
Extremely serious. It's an abrupt, severe worsening of thyrotoxicosis, often in Graves' patients triggered by stress, like infection or surgery. High fever, extreme tachycardia, potential heart failure, delirium. It's a medical emergency with high mortality if not treated aggressively.
Is there a quieter version?
Yes, epithetic hyperthyroidism, usually in the elderly. They might not have the classic jittery symptoms, but present with things like unexplained weight loss, worsening heart failure, or new atrial fibrillation. You need to check thyroid function.
Lab diagnosis low TSH is key for primary hyperthyroidism.
Yes, in primary disease, thyroid problem, the high T4-T3 feeds back and suppresses TSH. So low TSH plus high free T4 is a classic pattern. Sometimes only T3 is high. T3 toxicosis. If TSH is high, along with high T4-T3, that points to a secondary cause, like a rare TSH-secreting pituitary tumor.
And radioactive iodine scans help sort out the cause.
Very useful. Graves shows diffuse high uptake across the whole gland. A toxic adenoma shows a single hotspot with the rest of the gland suppressed. Thyroiditis shows very low uptake because the gland isn't actively making hormone, just leaking stored stuff.
Treatment for Graves.
Multiple options. Beta blockers for symptom control, thionamide drugs like methimazole or PTU to block hormone production, radioactive iodine therapy to ablate gland tissue, or surgery to remove the thyroid.
Let's focus on Graves' disease itself, autoimmune, right?
Yes, the root cause is autoimmunity. The body makes antibodies against the TSH receptor on thyroid cells. Most commonly, these are thyroid-stimulating immunoglobulins, TSIs. They mimic TSH, constantly telling the thyroid to make more hormone.
So the immune system is hijacking the controls.
Pretty much. Less often, there can be blocking antibodies instead, causing hypothyroidism. Morphologically, the gland is diffusely enlarged, hyperplastic follicles, lots of lymphocytes, and that ophthalmopathy and the skin thickening on the shins, pretubular myxedema, are also autoimmune processes driven by inflammation and deposition of glycosaminoglycans in those tissues.
So the eye and skin stuff isn't just a side effect of hormones, it's part of the immune attack.
Correct. And importantly, the eye disease can sometimes run its own course, even if the thyroid levels are controlled. People with Graves are also at higher risk for other autoimmune diseases.
Okay, let's flip to the other side. Hypothyroidism, not enough hormone.
Decreased circulating T3 and T4. Severe form in adults or kids is myxedema. In infants, young children, it's cretinism, devastating developmental impact if not caught early.
What does myxedema look like? The opposite of hyperthyroidism.
Very much so. Everything slows down. Fatigue, apathy, mental sluggishness, slowed speech, slowed movements. Feeling cold, weight gain, constipation, dry, cool skin. Heart rate slows, cardiac output drops.
And that characteristic puffy appearance.
Yes, that's due to accumulation of matrix substances, glycosaminoglycans in the skin and tissues. Causes non-pitting edema, coarse facial features, enlarged tongue, deep voice. Also, hypothyroidism adversely affects lipids, high cholesterol, high LDL, increasing cardiovascular risk.
What causes it? Again, primary versus secondary.
Yes. Primary means the thyroid itself failed. Secondary central means the pituitary or hypothalamus isn't providing the TSH stimulus. Primary is much more common.
Causes of primary hypothyroidism.
Worldwide, the biggest cause is iodine deficiency. In iodine-sufficient areas, like the U.S., the most common cause by far is autoimmune. Hashimoto thyroiditis.
Hashimoto's again?
Yes. Other primary causes, destruction from surgery or radiation, post-ablative, certain drugs, lithium amiodarone, congenital problems, thyroid didn't form right, or enzyme defects, dishormonogenetic goiter. Many primary causes lead to goiter as TSH rises trying to stimulate the failing gland.
And secondary central causes.
These are due to pituitary failure, no TSH, or hypothalamic failure, no TRH, rare, caused by anything damaging those areas. Tumors, trauma, radiation, key differences from primary.
Right.
No hyperpigmentation, because ACTH, MSH aren't high, and usually normal aldosterone levels, so no major salt-potassium issues.
Let's talk thyroiditis inflammation. Hashimoto's we know is autoimmune, causing destruction.
Right. The most common cause of hypothyroidism, where iodine is plentiful, typically middle-aged women. Chronic immune attack leads to fibrosis, gland failure, see lymphocytes, Hürthle cell changes under the microscope. Usually presents as painless goiter and hypothyroidism, though can have a brief initial hyperthyroid phase.
Hashimotosis.
Then there's subacute lymphocytic or painless thyroiditis.
Also thought to be autoimmune. Often occurs postpartum. Usually presents with mild, painless goiter and a transient hyperthyroid phase, hormone leak, often followed by transient hypothyroidism, and sometimes progresses to permanent hyperthyroidism like Hashimoto's.
And granulomatous or Decurvain's thyroiditis is less common. Thought to follow viral infections. The absolute key feature, it's the most common cause of thyroid pain. Patients have neck pain, tenderness over the gland. Histology shows granulomas with giant cells. Also often has transient hyperthyroidism initially.
Pain, Decurvain's. Got it.
That's the clinical pearl.
Moving to goiter just means enlarged thyroid.
Yeah.
Due to TSH stimulation when hormone production is impaired.
Exactly. Gland enlarges trying to compensate. Classic cause is iodine deficiency, endemic goiter. Can also be genetic enzyme defects or goitrogen exposure.
Two main types mentioned, diffuse non-toxic and multinodular.
Diffuse non-toxic, or simple goiter, is a smooth, symmetric enlargement from generalized TSH stimulation, usually euthyroid, normal hormone levels. Problems are mainly mass effects if it gets big, can have hyperplastic phase, then colloid involution phase.
And multinodular goiter.
Much more common, especially with age. Results from cycles of hyperplasia and involution, leading to irregular, lumpy enlargement with distinct nodules. Can become massive, cause compression symptoms, airway, swallowing, neck veins, often euthyroid or subclinical hyperthyroidism.
Can they become toxic?
Yes, about 10% develop toxic multinodular goiter, Plummer syndrome, where nodules become autonomous and overproduce hormone, causing hyperthyroidism independent of TSH. Low risk of cancer within a multinodular goiter, 5%, but concerning if one nodule grows rapidly. Irregular morphology with fibrosis, hemorrhage, calcification is typical. Importantly, the nodules lack a true capsule, unlike adenomas.
Okay, thyroid neoplasms. When is a solitary nodule suspicious?
Red flags. Solitary nodule, young patient, male patient, history of head neck radiation. On scans, cold nodules, don't take up iodine, are more worrisome than hot ones. Fine needle aspiration, FNA biopsy, is key for evaluation.
Thyroid adenomas, follicular adenomas specifically.
These are benign, solitary, encapsulated tumors of follicular cells. Most are non-functional. A few are hot, toxic adenoma causing hyperthyroidism. The absolute defining feature is an intact, complete fibrous capsule surrounding the tumor with no invasion through it or into blood vessels.
So diagnosis requires seeing the whole capsule.
Yes, often needing surgical removal to examine it thoroughly. If the capsule is breached, it's carcinoma. Prognosis for adenoma is excellent.
Right, the capsule is the dividing line. Now, thyroid carcinomas.
Most common endocrine cancer, generally good prognosis for most types. Risk factors, radiation exposure, especially childhood. Iodine deficiency for follicular type. Specific genetic alterations are known drivers.
Like the BRAF mutation in papillary cancer.
Exactly. Papillary often has BRFAF mutations, especially V600E, linked to worse prognosis, or RETPTC or NTRK gene fusions. Follicular often has RAS mutations or PACX8PPRG fusions. Medullary has RET point mutations, different from the papillary fusions. Aggressive transformation often involves TP53 or TERT mutations. This molecular understanding is huge.
Let's break down the types. Papillary thyroid carcinoma, PTC, most common.
Yes, 85%, often younger adults. Can be single or multiple foci. Diagnosis hinges not just on papillae, but on characteristic nuclear features. Orphan annii, nuclei clear centers, nuclear grooves, pseudo-inclusions, psammoma bodies, calcifications are also typical.
How does it spread?
Commonly via lymphatics. Cervical lymph node metastases are frequent, even at diagnosis, but often don't drastically worsen the generally excellent prognosis. Call cell variant is more aggressive.
Follicular carcinoma next.
5–15% of cases. More common where iodine is deficient, affects slightly older patients. Looks like follicles, can resemble adenoma. The diagnosis requires finding invasion, either through the tumor capsule or into blood vessels, vascular invasion. Without invasion, it's an adenoma.
Invasion is the key, spread pattern.
Unlike papillary, follicular tends to spread through the bloodstream, hematogenously, to lungs, bone, liver. Lymph node spread is less common.
Poorly differentiated and anaplastic sound bad.
They are. Where, 5%, occur in older patients, very aggressive. Poorly differentiated, Still shows some follicular features, but looks more disorganized, high mitotic rate. Anaplastic is highly undifferentiated, often rises from a pre-existing differentiated cancer, rapidly fatal, doesn't look or act like thyroid tissue anymore.
Lastly, medullary thyroid carcinoma, MTC.
Arises from the C cells, parafollicular cells, not follicular cells. C cells make calcitonin, so calcitonin is a key tumor marker. But 80% sporadic, 20% familial, part of MEN2A or MEN2B syndromes or familial MTC alone. Familial cases are due to germline RET mutations.
What's characteristic morphologically?
Nests or sheets of cells, often with amyloid deposition in the stroma, derived from calcitonin.
Clinical picture.
Neck mass may be dysphagia, hoarseness, can secrete other hormones causing diarrhea, VIP, or Cushing's, ACTH. Calcitonin and CEA are useful blood markers. Familial cases, MNN2, have associated tumors, pheochromocytoma, parathyroid, and may warrant prophylactic thyroidectomy if RET mutation is found. MTC in MN2B is particularly aggressive. RT inhibitors are now used in treatment.
Okay, thyroid covered. Moving down to the adrenal glands sitting on the kidneys. 2 glands in one.
Exactly. Outer cortex, inner medulla. Totally different functions.
Cortex makes steroids.
Right. 3 zones. Outer glomerulosa, mineralocorticoids, aldosterone saltwater balance, middle fasciculata, glucocorticoids, cortisol stress, metabolism, and some sex steroids. Endoreticularis, mainly sex steroids, androgens, and some cortisol.
And the medulla.
That's made of chromaffin cells, part of the sympathetic nervous system. Makes catecholamines, epinephrine, adrenaline, and norepinephrine for the fight or flight response.
Okay, adrenal cortex hyperfunction. Let's start with too much cortisol, Cushing's syndrome.
Right, the clinical state from excess glucocorticoids. Most common cause overall is taking steroid medications, iatrogenic. If the body's making too much endogenous Cushing, it's either ACTH dependent or ACTH independent.
ACTH dependent.
About 60–70% of endogenous cases, usually caused by an ACTH producing pituitary adenoma that's Cushing disease. Less often, ACTH comes from a non-pituitary tumor, ectopic ACTH, like small cell lung cancer or a carcinoid. Very rarely, a CRH producing tumor.
And ACTH independent.
Problem is in the adrenal itself, making cortisol autonomously. ACTH levels are low due to feedback. Accounts for 20–30%. Most common cause here is a cortisol-producing adrenal adenoma. Less often, adrenal carcinoma or bilateral hyperplasia. Dexamethasone suppression tests help distinguish these causes.
What do the adrenals themselves look like?
Depends on the cause. Exogenous steroids, bilateral atrophy, ACTH suppressed, ACTH-dependent pituitary topic cell lateral hyperplasia, diffuse or nodular from constant stimulation. Primary adrenal tumor, adenoma carcinoma, C-tumor 1 gland, atrophy of the surrounding cortex, and the opposite gland, ACTH suppressed by the tumor's cortisol.
The clinical signs are quite striking.
Very. Central obesity, trunk, face, upper back, moon face, buffalo hump, thin limbs, thin skin, easy bruising, purple striae. Also hypertension, diabetes, glucose intolerance, osteoporosis, infections, mood changes, maybe hirsutism, menstrual issues from androgens.
Okay, what about excess aldosterone, primary hyperaldosteronism?
Too much aldosterone made by the adrenal, independent of the normal renin-angiotensin system.
Yeah.
Causes sodium water retention, hypertension, causes potassium loss, often hypokalemia, though maybe normal kalemic now, leading to muscle weakness, fatigue, sometimes tetany, high cardiovascular risk long-term.
What causes it?
2 main causes: an aldosterone-producing adrenal adenoma, Conn syndrome, accounts for 35%, often driven by specific ion channel mutations like KCNJ5, or bilateral idiopathic hyperplasia, around 60%. Adrenal carcinoma is a rare cause.
Diagnosis based on aldosterone and renin levels?
Yes. High aldosterone plus low renin is the key screening finding, confirmed with suppression tests,
Treatment.
surgery for an adenoma, medical management, aldosterone antagonists like spironolactone for bilateral hyperplasia.
Adrenogenital syndrome's excess androgens.
Caused by androgen-secreting adrenal neoplasms, more often carcinoma, or, more commonly in kids, congenital adrenal hyperplasia, CAH, inherited enzyme defects shunting steroid production towards androgens.
Now, the opposite, adrenocortical insufficiency. Not enough steroids.
Can be acute or chronic. Primary acute insufficiency, adrenal crisis, is a sudden, severe lack. Classic cause is Waterhouse-Friderichsen syndrome, massive adrenal hemorrhage, often with meningococcal sepsis. Rapid collapse, medical emergency care.
Scary. And chronic.
Chronic insufficiency is Addison disease. Progressive destruction of the adrenal cortex, need 90% loss for symptoms.
Causes of Addison's.
In developed countries, autoimmune adrenalitis is most common, 60–70%. Immune system destroys the cortex. Worldwide, infections like TB and fungi are major causes. Metastatic cancer can also destroy the glands. Rare genetic causes too.
Symptoms of Addison's. often subtle at first.
Yes, insidious fatigue, weakness, weight loss, GI upset. The key distinctive sign of primary insufficiency is hyperpigmentation, skin darkening, exposed areas, creases, scars, gums.
Why the hyperpigmentation?
Because the low cortisol means the pituitary cranks out tons of ACTH to try and stimulate the adrenals.
Mhm.
ACTH and MSH, melanocyte-stimulating hormone, share a precursor, so high ACTH means high MSH, stimulating pigment production. It's a marker of high ACTH drive. Also, in primary Addison's, you lose aldosterone. This causes mineralocorticoid deficiency, high potassium, low sodium, volume depletion, low blood pressure. Lack of cortisol adds hypoglycemia risk. Stress, illness, injury can trigger an acute adrenal crisis, vomiting, abdominal pain, shock, potentially fatal if not treated fast with IV steroids.
How is secondary insufficiency different?
Secondary is due to lack of ACTH from pituitary hypothalamic disease, tumor, radiation, chronic steroid use suppressing the axis. Key differences. No hyperpigmentation, ACTH is low. Aldosterone usually normal, it's mainly renin controlled, so no major salt-potassium imbalance or volume depletion. Still have cortisol deficiency symptoms.
That distinction is vital. And adrenal tumors can be non-functional too.
Yes, adrenocortical adenomas, or carcinomas, might not secrete excess hormones, often found incidentally, incidentalomas. Benign adenomas are typically well-defined, yellow, lipid-rich. Carcinomas are often larger, more invasive, prognosis is guarded. Familial syndromes like Liferameni increase risk.
Okay, inroads to the medulla, pheochromocytoma.
Tumor of the chromaffin cells, making excess catecholamines, epinephrine, norepinephrine, causes hypertension.
The hypertension is often episodic, paroxysmal.
Can be sustained, but often has dramatic paroxysms. Sudden severe hypertension plus the 5 Ps palpitations, headache, perspiration, sweating, pallor, and sometimes panic anxiety. Triggered by stress, exercise, pressure on the tumor. These crises can cause stroke, MI, arrhythmias.
Are they often genetic?
A significant proportion are linked to inherited syndromes. MNN2A and 2B, von Hippel-Lindau, VHL, neurofibromatosis type 1 and F1, and mutations in SDH genes. So genetic testing is important. Can be benign or malignant.
Treatment is surgery, but needs careful prep.
Absolutely. Surgical removal is curative if benign, but you must block the catecholamine effects with alpha and then beta blockers before and during surgery to prevent a catastrophic hypertensive crisis when the tumor is handled.
That leads nicely to multiple endocrine neoplasia, MNN syndromes, inherited predisposition to multiple endocrine tumors.
Right. Autosomal dominant inheritance. Tumors often appear earlier, are often multifocal within a gland or affect multiple glands, may be preceded by hyperplasia, and can sometimes be more aggressive than sporadic counterparts.
MN type 1 Vermeer syndrome.
Caused by MNN1 gene mutations. Classic triad is the 3PS. Parathyroid, hyperplasia adenomas causing hyperparathyroidism, very common, 80-95%. Pancreas, endocrine tumors. Panettes, often aggressive, can be functional like gastromas and selenomas or non-functional. And pituitary anterior adenomas, often prolactinomas. You can also see carcinoids, adrenal thyroid adenomas.
And MN type 2 RET gene mutations.
Yes, 2 main subtypes, 2A and 2B.
MN2A, Sibyl syndrome.
Triad of medullary thyroid carcinoma, MTC virtually 100% penetrant, pheochromocytoma 50%, and parathyroid hyperplasia, hyperparathyroidism, 20-50%.
MMN2B.
Also MTC, often more aggressive, and pheochromocytoma, but no primary hyperparathyroidism, instead associated with mucosal neuromas, lips, tongue, eyelids, intestinal ganglion neuromas, and a marfanoid body shape, usually a specific RET mutation causing strong activation. Familial MTC without other features is now often grouped under MN2A.
So genetic testing is crucial for families with MTC or these syndromes.
Essential for identifying carriers, allowing surveillance and potentially prophylactic thyroidectomy, especially given the high risk and potential aggressiveness of MTC in MNN2.
Incredible how one gene links these different glands. Okay, let's shift to the endocrine pancreas. Blood sugar control central here.
Right. Scattered within the main pancreas are the islets of Langerhans clusters of endocrine cells. Beta cells make insulin, alpha cells make glucagon, delta cells make somatostatin, PP cells make pancreatic polypeptide.
Insulin and glucagon are the main players in glucose balance.
They are the yin and yang. Glucose levels depend on liver glucose production versus peripheral tissue uptake. Muscle is key, regulated by insulin and glucagon. Fasting state, low insulin, high glucagon, liver releases glucose. Fed state, high insulin, low glucagon, tissues take up glucose, liver stores it.
Tell us about insulin.
Made in beta cells, co-secreted with C-peptide, useful marker of endogenous insulin production. Main stimulus for release is rising blood glucose. Glucose enters beta cell, triggers ATP production, calcium influx, insulin vesicle release. Gut hormones called incretins, GIP, GLP-1, released after eating, give a big boost to insulin secretion too.
And insulin's actions.
Anabolic, the most potent anabolic hormone, promotes glucose uptake into muscle and fat via GLUT4 transporters moving to the cell surface, stimulates protein synthesis, inhibits liver glucose production, promotes glycogen storage, basically tells the body store energy.
Failure of the system leads to diabetes mellitus.
Chronic hyperglycemia, hugely prevalent, major cause of long-term damage. Kidney failure, blindness, amputations, heart disease. Type 2 is soaring, even in kids. Prediabetes is also very common.
Diagnosis, blood tests.
Yes. Fasting glucose, random glucose with symptoms, oral glucose tolerance test, OGTT, or HbA1c, reflects average glucose over 3 months. You usually need confirmation on a separate day unless symptoms are clear and glucose is very high. Acute stress can cause temporary high glucose.
Let's differentiate type 1 and type 2.
Type 1 diabetes, T1D, is autoimmune destruction of beta cells, leads to absolute insulin deficiency, usually diagnosed in kids, young adults, 5–10% of all DM. Autoimmune process simmers for a while, then often abrupt clinical onset.
So T1D, immune attack killing beta cells.
Fundamentally, yes. T-cell mediated. Type 2 diabetes, TTD, is the vast majority, 90–95%. Combination of insulin resistance, tissues don't respond well to insulin, and eventual beta cell dysfunction. Can't produce enough insulin to overcome the resistance relative deficiency. Strongly linked to obesity.
What drives the insulin resistance and beta cell failure in T2D?
Resistance is linked to obesity, especially visceral fat. Adipokines released from fat, chronic low-grade inflammation from nutrient excess, fatty liver. Beta cell failure develops over time due to glucotoxicity, chronic high glucose is toxic, lipotoxicity, excess fatty acids, impaired incretin effect, amyloid deposition in islets, plus underlying genetic susceptibility.
So it's a complex mix of lifestyle, environment, and genetics. Classic symptoms are the polys.
Polyuria, frequent urination, polydipsia, thirst, polyphagia, hunger. Unexpected weight loss despite hunger can be a key sign, especially T1D.
What about acute complications, DKA?
Diabetic ketoacidosis, primarily in T1D. Severe insulin deficiency plus high counterregulatory hormones, very high glucose, dehydration, breakdown of fat into ketone bodies, metabolic acidosis, life-threatening emergency.
HHS.
Hyperosmolar, hyperglycemic state, more common in T2D, extremely high glucose, severe dehydration and hyperosmolarity, but usually without significant ketoacidosis, enough insulin present to prevent ketosis, also very serious.
And hypoglycemia.
Low blood sugar, most common acute complication of treatment, too much insulin medication, missed meal, etc.
The long-term chronic complications are the really devastating part.
Absolutely.
Yeah.
Driven primarily by chronic hyperglycemia, glucotoxicity, damages blood vessels large and small, nerves, affects eyes, retinopathy, kidneys, nephropathy, nerves, neuropathy, heart, and peripheral arteries. Tight glycemic control is key to prevention slowing progression.
What do these complications look like pathologically?
Pancreas. T1D shows islet loss, immune infiltration, and cellitis. T2D shows more subtle beta cell loss, often amyloid deposits in islets. Vasculature. Microvascular is accelerated atherosclerosis. Heart attacks, strokes, peripheral artery disease, gangrene amputation risk skyrockets. Microvascular is thickening of capillary basement membranes everywhere, kidneys, eyes, nerves. Also hyaline arteriolosclerosis, thickening of small artery walls.
Kidney damage, diabetic nephropathy.
Leading cause of end-stage renal disease, glomerular changes. Basement membrane thickening, diffuse mesangial sclerosis, pathognomonic nodular glomerulosclerosis, Kimmel-Seal-Wilson lesions, also arterial thickening, increased risk of kidney infections.
Eye damage, retinopathy.
Leading cause of adult blindness. Non-proliferative, hemorrhages, exudates, and proliferative, abnormal new blood vessel growth, prone to bleeding retinal detachment.
Nerve damage, neuropathy.
Peripheral neuropathy, pain, numbness, tingling and stocking glove pattern. Autonomic neuropathy, affecting gut, bladder, BP. Mononeuropathies.
And infection.
Increased susceptibility due to impaired immune function and poor circulation. Skin infections, pneumonia, eudyspial Foot ulcers are a huge problem due to neuropathy plus vascular disease, infection, gangrene, amputation risk.
A grim picture of chronic damage.
Okay. Briefly, pancreatic neuroendocrine tumors.
PANETs.
Rare tumors from islet cells can be benign or malignant. Malignancy based on size, invasion, METs, proliferation rate, often functional secreting hormones.
Like insulinomas.
Yes, most common type. Beta cell tumor making excess insulin hypoglycemia, usually benign. Gastrinomas make Gastrin-Zollinger-Ellison syndrome, severe ulcers, often malignant, can be duodenal. Others include glucagomas, somatostatinomas, lipomas, each causing specific syndromes.
Genetic links here too.
MN1 syndrome is a key one. Also, sporadic mutations in MN1, MTR pathway genes, PTNTSC2, ATRX, DAXX.
Finally, the tiny pineal gland.
Pinecone-shaped, deep in the brain. Pineocytes secrete melatonin, regulating circadian rhythms, sleep-wake cycles, sometimes called the third eye.
Clinically significant issues.
Really only tumors, according to the sources. Pineoblastoma is aggressive and pineocytoma is less aggressive. Both are rare.
Wow, we have really covered a vast territory there, from the pituitary control tower down to the pineal gland.
We definitely took that deep dive, explored the intricate communication, the feedback loops, the specific glands and hormones, and then the consequences when that delicate balance is disrupted, from subtle biochemical changes to overt systemic diseases.
And the goal was that professional level understanding, right? Connecting the dots between, say, a specific gene mutation like GNAS and the clinical picture of acromegaly, or understanding why histology is crucial for distinguishing a follicular adenoma from a carcinoma.
Exactly. It's not just memorizing facts, but grasping the mechanisms. Why low cortisol in Addison's causes hyperpigmentation, how chronic high glucose leads to vascular damage, understanding the why behind the what.
So what's the final thought here? The endocrine system is this masterclass in interconnectedness, isn't it? Where a tiny glitch in one spot can ripple outwards with huge consequences.
It really is. Think how diverse the presentations are. Visual problems from a pituitary tumor, skin rashes from a glucagonoma, the systemic devastation of diabetes. It highlights the intricate harmony needed for health.
It's a profound reminder of the body's complexity and, honestly, how much more there always is to learn. Hopefully, this deep dive gave you, our listener, some solid ground and perhaps sparked some new questions about this incredible system.